Good morning, everybody. This is Dolly Kurbitsky. As you know, I'm president of PF Warriors, and I'm really happy to see you all here today. I am really hoping that we are able to answer some questions for you. Dr. Jeffrey Swigris has graciously allowed us to speak this morning, and we're still awaiting his arrival. I apologize. He's these guys are working men. So he's doing a procedure this morning and it ran a little bit over. So we're going to talk a little bit before he joins. And I'm sure you're really going to like this meeting. Perhaps we could go through the phases of clinical trials so that it makes it a little bit easier. Some of you may be familiar with it and some of you may not. So this is explanation through the American Society of Research Professionals. So, as you may or may not know, clinical trials are lumped into 4 different phases. And the trial that everybody is really interested in right now was the Fibrosis trial that finished and got a positive result for the endpoint. So phase 1 studies are studies that are just beginning. So that is exploratory. They look to see what can happen. Sometimes it's done with people that have a specific disease. Other times it is done with normal controls, so people without lung disease, just to look for safety and feasibility. Once that gets positive results, they move into a phase 2 study. Phase 2 studies, it doesn't say this on the screen, but phase 2 studies are really divided into two different parts. You may have seen phase 2A and 2B. 2A studies can be smaller studies. They still are looking for basically the same thing. They're looking for further safety of the drug. They want to look at some effectiveness, but the main reason is really to further assessment of the safety. Is it safe? They also look at different dosages. Phase 2B studies are a little further along and they use the results from a 2A study. And I'm sorry, but I didn't find any place that really had these broken out for the language. So that's why we pulled this one up. And then, of course, once those 2A and 2B studies are done, they move on to phase 3, which is the really exciting part, because once you get positive results from those phase 3 trials, they can take that information and go to the FDA and apply for marketing of the drug. So as you know, Fibrosis reached the endpoint for phase 3, which means they can move forward with some of that information to ask for marketing of the drug. So we're awaiting that right now, and we're really hopeful they move forward with approval for IPF and for PPF. So that's a pretty large group of people. Unfortunately, it's 2 different approval processes because it was 2 different drugs. So let's see, Dr. Swigris just logged in. So Dr. Swigris, we're really pleased to see you, and thank you for making it. I understand you're probably rushing about this morning, but many of you know Dr. Swigris. He is in the Interstitial Lung Disease Clinic at National Jewish Health. He has been there for, I say, 16 years. Is that right?
Oh, how long have I been here? Dolly, we're approaching 20.
Oh my goodness. Okay, sorry guys, I'm just old. Because I remember when I worked at National Jewish when Dr. Swigris joined us. And we were really excited because he revolutionized our clinic and changed how we did things for a positive way, and I can't thank him enough. So I'm going to turn this meeting over to him. We were just going through the phases of clinical trials. just to sort of help give some background, because everybody is really interested in what's going on. And really, with the Fibronair trial coming with positive results, and then a lot of other things that happened at ATS that I know that you've talked about in the past. So, Dr. Swigris, you have the screen.
All right, great. Hi, everyone. Thank you so much for having me. I was going to dig into the Fibronair results, if that's okay with everyone. I see there's a question in the chat about drugs and so forth. So Nerandomilast, this new drug that we anticipate approval, as Dolly was mentioning, probably the word on the street is Q4 of 2025, maybe as early as October, but not sure. And I thought because the results of the trial, they're going to there's some nuance there, and I'd like to try and explain that and share these results with you, if that's okay. And then we can talk about some other things too. Like Dolly mentioned, it's there's a lot in the pipeline here in terms of new drugs. We have inhaled drugs coming down the pike in later phases of testing. Metformin, we're actually going to see, so metformin, the diabetes drug, is going to be tried in IPF. And there's a whole bunch of other drugs that are coming down the pike. But I think first I would like to really dig into the data on nerandomilast so that we all have a really good understanding of what these results show us. So I think most of you, if not all of you, are very familiar with lung capacity and specifically FVC. This is that maneuver for those of you who are patients where you go in and a technician, you're on a mouthpiece, and the technician will say, take the biggest breath in that you possibly can, and you blow, 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 blow all of that air out, and the computer measures how much air just came out. Right? That's a forced, because it's a forced maneuver, vital capacity. That is a measure of lung capacity. And FVC, that measure, is something that trials have used as the primary endpoint now for at least 10 years, and that your practitioners who are following you for your interstitial lung disease almost certainly follow on a regular basis and probably talk to you about the results when you come in. I know I do with my patients. We look at FVC over time so that we get a sense of the physiology. It's one metric of disease severity. So hopefully that all makes sense, because FVC is what we're going to be spending a good deal of time on here. So this trial was 1,100 patients with idiopathic pulmonary fibrosis. There, as Dolly mentioned, there was a sister trial or a parallel trial in patients with progressive pulmonary fibrosis that is not IPF. And I'm not going to talk about those yet. If we have time, I'll do the same thing with that trial. So some background here. In 2014, Ofev, nintedanib, the generic, and pirfenidone, Esbriet, were approved by the FDA. And if we reflect back on those trials, what we saw was that FVC over 52 weeks declined half as much in people on treatment versus people on placebo. So the results really were interchangeable. Two different companies, two different trials. If you were on nintedanib, you lost half as much FVC, meaning your FVC or your lung capacity declined half as much compared with placebo. And we saw the exact same results in the trial of pirfenidone. And the FDA said, we're going to approve it. There's no other therapies, even though these aren't the magic bullets for IPF. It's certainly a major advancement over what we had in the past, which was essentially nothing. So to get granular, the treatment arms in each of those trials back in 2014, so nintedanib or pirfenidone, lost about 100 cc's or so, 100 mLs of lung capacity. Those are average values of big groups of patients, right? So on average, the group of patients who were on drug lost 100 cc's, and the group of patients on placebo lost on average twice as much, or 200 cc's. Does that make sense to everyone? Pretty much. Okay. All right. So now let's fast forward a decade and talk about this trial. This new trial, this new drug is called Nerandomilast. And don't blame me for the titles of these drugs. I have nothing to do with their names. It seems like companies and the FDA and drug naming bodies just try and make the longest, most ridiculous names that they can come up with. But this is what it is, Nerandomilast. So in this trial, 1,100 patients with IPF were enrolled. And when a patient was enrolled in the trial, they were randomized to one of three arms. And remember, these trials are blinded, so nobody knows what the patient is taking until the very end, and the blind is broken, and then we are informed what our patients were taking. And then we usually share that with our patients. So patients come into the trial. A third of them get randomized to the higher dose of nerandomilast, 18 milligrams twice a day. A third of them get randomized to the low dose, 9 milligrams twice a day, and a third get randomized to placebo. Now, an important thing to consider here is that I'm going to say 80%, it was 78% of patients who came into the trial were taking either nintedanib or pirfenidone, right? So patients could have been taking nintedanib, could have been taking pirfenidone, or could have been taking nothing when they were enrolled in the trial. Turns out 80% of people, so the vast majority of patients were actually taking one of those two approved medicines and then came into the trial and then got randomized to high dose, low dose, or placebo on top of what they were already taking. Does that make sense to everyone? Yeah, okay, good. I'm seeing some heads nodding. All right. So if you follow my pointer, we're going to look at this box over here in A, and this is, as it says, the overall trial population. So this is all comers grouped together. So whether you were on pirfenidone, nintedanib, or nothing going into the trial, this is the results for everybody grouped together. And what I want you to remember is that because of randomization, about 80% of people in each group would have been taking nintedanib or pirfenidone. So 80% of people in the high-dose nerandomilast group, 80% of people in the low-dose nerandomilast group, and 80% of people in the placebo group would have been taking either nintedanib or pirfenidone. I hope that makes sense as well. And the breakdown is 45% of people were on nintedanib, 35% of people were on pirfenidone, and the rest would have been on placebo within each of those groups. So these numbers here that you see, right? This is the change in FVC, change in lung capacity, change in big breath in, blow, 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 from baseline to 52 weeks. It's an average value of, in this group, 392 patients. In this group, 390 patients, and in the placebo arm, 391 patients. So what you can see is negative values, meaning that FVC declined, so lung function still worsened even if you were on the drug, and lung function declined less in the high dose group than in the low dose group, and the low dose group was less than the placebo group. So reflect back to what I said about 2014 when nintedanib and pirfenidone got approved. What we saw was a decline of about 100 cc's or so in the treatment group and 200 cc decline in the placebo group. So you might say, well, gosh, this is about what I would expect from nintedanib, Ofev alone, or pirfenidone, Esbriet alone. But 80% of the people in this group here would have been taking Ofev or Esbriet plus this new drug. So what the heck is going on? I would have hoped that Ofev or pirfenidone plus the new drug, we would have seen less decline than 100 cc's, maybe 70, maybe 80, maybe 50. So what is unknowable, but what we think is happening here, is that these 1,100 patients, or at least most of them, were very motivated to go into a trial, and perhaps because they were getting worse at the time, right? So you might imagine yourself, you're on Ofev, maybe you've tried pirfenidone, maybe you haven't, you're on Ofev, and your doc says, well, gosh, your FVC is going down, right? We're still declining despite taking Ofev, presumably less than you would decline if you weren't on Ofev. But as a patient, you might say, well, doc, I'm on Ofev, I'm declining. What else do you have for me? Well, there's, pirfenidone's the only other drug that's approved, but we have this trial, and the phase 2 data looked pretty promising. So what do you think about going into this trial? And you have a 2 out of 3 chance of getting randomized to this drug that we think may be beneficial. What do you think? So the thinking in the field is that probably those patients who were on background therapy, those 80% who got enrolled in this trial, many of them were probably declining going into the trial, looking for some added benefit of something. And that's why we're seeing the numbers that we're seeing, why we're seeing the decline in the high dose group that is really equivalent to what we saw a decade ago in Ofev alone. So let's look at B now. Remember, 80% of people who went into this trial were taking Ofev or Esbriet. 20% of people were not. So this is the subgroup of patients who were not taking Ofev or Esbriet. Same thing, we had 3 groups. You'll see the numbers smaller because we're only dealing with 20% of this 1,100 patient cohort. So a third of patients, they're not taking any antifibrotic therapy. A third of them get randomized to the high dose Nerandomilast, a third to the 9 milligrams twice a day, and a third to placebo. And I look at this, and this is nice. This is better than what we saw with Ofev or Esbriet alone back in 2014. Remember, those numbers were about 100, 120 cc's-ish is what we saw in the treatment arms in those trials. And now we got 79, 70 cc decline in FVC in the treatment arms. It's interesting that it doesn't look like the high dose was any better than the low dose of the nerandomilast, but both of them were better than placebo, right? And remember this placebo group here, these are patients who are ultimately not taking anything. They're not taking OFEV, they're not taking Esbriet, and they didn't get randomized to the study drug. So what somebody like me might say is, well, this is interesting as well, because I would have expected the placebo group to lose about 200 cc's over this year, and the placebo group only lost 150-ish cc's. So the placebo group lost a little bit less than I would have expected, but the treatment arms, this is better than what we saw for OFEV or Esbriet a decade ago. So that's nice. Now let's continue on. So left side of my screen, patients taking nintedanib or OFEV now, right? So remember, 20% of patients were not taking anything. 80% of patients were taking either OFEV or Esbriet. So this is the subgroup that came into the trial. They're on OFEV and they get randomized to high dose new drug, low dose new drug, or placebo. And what you see here is, once again, the high dose group loses lung function, right? FVC still declines. And this is very similar to what we would expect from OFEV alone back in the day. The lower dose, the 9 milligrams twice a day, lost a little bit more than the group on high dose. And each of those lost quite a bit less than the placebo group. So this placebo group, interestingly, same thing as I said for A, this 190, 200-ish cc decline in FVC is about what I would expect for a true placebo group. But these people were taking OFEV, right? So again, going back to what is it about these people, this particular group going into this trial? Could it be they're on OFEV, they're still declining, looking for an opportunity of different therapy? Hey, there's this trial, I'm going to go into this trial. But it is clear that despite that, OFEV plus the new drug, you lose less than if you're on OFEV alone. I'm going to talk about D, then I'm going to either stop sharing or have somebody grab my screen so that I can go back and answer questions. So let's cover D. Now we're looking at the 35% of patients who were taking pirfenidone coming into the trial. So you're on pirfenidone, you get randomized to high dose new drug, low dose new drug, or placebo. What you see here is really interesting, isn't it? I want you to focus on this middle bar. This is the average decline in FVC in the low dose group. So low dose new drug, 9 milligrams twice a day. You lose exactly statistically as much as the placebo group. So new drug plus Esbriet is equivalent to Esbriet alone, and there's really no beneficial effect apparent from that combination. So what's up with that? Well, it turns out that there's a drug interaction between pirfenidone and nerandomilast. So pirfenidone will chew up or metabolize or accelerate the metabolism of the new drug. So it turns out if you were on 9 milligrams twice a day, you essentially got none of that drug active in your bloodstream. And if you were on 18 milligrams twice a day, the metabolism was such that it was like you were only getting 9 twice a day. So this is something that the company and practitioners are going to have to wrangle with a little bit, this interaction. But what these results do tell us is that high dose nerandomilast plus Esbriet is better than Esbriet alone in this population. Again, with the caveat that that placebo group is losing more than we would expect for a group of patients on Esbriet. Over a year, a decade ago, that group would have only lost about 100, 120 cc's or so. So there's some nuance here. There's some caveats here that are going to take some discussion when when this gets approved and you're trying to make a decision with your doc or your practitioner, is this drug right for me or is it not? And maybe what I'll do is let's go to the side effects. I can summarize the secondary outcomes quickly, and that is, it looked like there was no difference in secondary outcomes, meaning respiratory hospitalizations, acute exacerbations, death in patients taking nerandomilast, meaning that it did not seem to have beneficial effects on those outcomes, nor did it look like there were any beneficial effects on symptoms or quality of life. And we can dive into that more if we want to, but let's go to adverse effects, and then I'll stop sharing. So a lot of data on this screen here. These are adverse events. Same groups that we looked at before, the A, B, C, and D panels. So you have all patients, then you have the 200 or 20%-ish on no background. You have the 45% who are on nintedanib coming into the trial, and then the 35% who were on pirfenidone. And it's really diarrhea, again, is the most common side effect far and away. And it looks like the diarrhea is more prominent for sure in those folks who came into the trial on OFEV. So if you look at no background therapy, diarrhea, 23 subjects, 26% here, diarrhea in the high dose, 17% diarrhea in the low dose. Remember, there is, placebo groups have side effects as well. And that's partly because, who doesn't have diarrhea every once in a while? And when you ask, are you having this, that, or the other, you're going to get yes occasionally. So 26% high dose, new drug, no background therapy versus 62% high dose new drug plus OFEV, 23%. Diarrhea isn't really a common side effect at all of pirfenidone. So pirfenidone plus high dose new drug, 23% diarrhea. That's really the one that I think captures my eye the most, and I think will capture my patients' eyes the most. If you look at events leading to the interruption of the trial regimen or discontinuation rate, so discontinuation due to diarrhea was pretty darn low, about 13% in the OFEV group plus high dose nerandomilast, 13% discontinued. But outside of that combination, that dose, there really weren't significant discontinuation, 1%, 2%, 6% due to diarrhea. So other side effects here that we can look at, if we go no background therapy, there's really not a whole lot of differences here. COVID-19, maybe a few more in the high dose Nerandomilast than the low dose in the placebo. I'm not sure what to make of that. I mean, really a pretty impressive side effect profile, I think. So let me try and stop sharing. So John asks, well, why can't we just find out if people were declining going into the trial? And one could, I mean, you could go back and look at those. I think that, and maybe somebody will, but you know, that's a pretty big ask to go back and have somebody, you know, look at that. But I think it would be really beneficial and help explain that. Otherwise, we're doing this guessing, right? Like, well, maybe this and maybe that and maybe that. And perhaps somebody will do that, because I think that would be really informative and interesting. Yeah, so let me tell you how many patients were, I don't know how many patients were newly diagnosed, but I can tell you that the average duration of IPF was a lot longer, I mean, relatively, than what we typically see in trials. The time since diagnosis on average was about 3.5 years. And the average lung capacity, or FVC, your doctors might share with you your percentage. You might ask your doc or your practitioner, well, okay, my FVC is 3.1 liters. How does that compare for somebody in my demographic, right? So we can give you a percentage of what we would expect based on your sex, your age, and your height, right? Sex, age, and height, we can compare your value to somebody with those same characteristics as you. And in this trial, patients were on average 78% of what we would predict for their sex, age, and height. So remember, 80% or above is considered normal. So they are mildly impaired, you know, below normal for sure, but mildly reduced lung capacity. Diffusing capacity, that other value that you might do where you take a big breath in and you hold your breath for a period of time. At my center, it's 6 seconds. And we're trying to figure out how well is oxygen getting down into all the tiny little air sacs, the alveoli of the lung, the sponge or the meat of the lung, through the membranes or the walls of those air sacs, and into the blood vessels that surround. That's diffusion, right? Oxygen has to diffuse from inside the alveolus, the air sac, through the wall, into the blood vessels that surround. And that's an important test because fibrosis is occurring within the wall, causing that wall to be thick and not allowing oxygen as free a movement into that blood vessel. So that DLCO value in the trial, they were about 50%. So 78%-ish lung capacity, about 50% diffusing capacity. And that the diffusing capacity is moderately reduced. And we often see that imbalance or that discrepancy between lung capacity and diffusing capacity. The diffusing capacity on balance tends to be a bit lower than the lung capacity in patients with IPF. So it's interesting, you know, mild reduction in FVC, pretty long duration of disease relative, right? 3.5 years. We're used to seeing closer to like 2.5 years. So although there were undoubtedly some patients who were newly diagnosed, on average, you know, this is a cohort that had IPF for quite a while. So what I can tell you, what I envision here is there's no question. Let's say this drug gets approved. Let's say that insurance companies pay for it, and maybe there's, foundational grants and those kinds of things, just like with OFEV and Esbriet. And OFEV, nintedanib, will be going off patent, so we will be generic here in not too long. But let's say this is available. For sure, my patients are going to come in and ask me, well, Swigris, what do you think? I'm either on OFEV or not, or on Esbriet or not, or didn't tolerate or whatever. Should I go on this drug? And what I would say to my patient is, again, why not? I think that what the data would suggest is that this drug slows progression. And I think for patients who are either not tolerating background or not on background therapy for some reason, I think it's a no-brainer. And I don't use side effects to dissuade patients. I've said this before, I think, on this forum. Yes, I'm going to tell my patients about side effects, but I would never say, oh, I'm not going to prescribe this drug to you, or I don't think you should take this drug because you might get diarrhea, right? Well, the chandelier in my office could fall on my head right now too, but is it going to happen? I don't know. It might, probably would hurt, but I would get over it, right? Side effects from these medicines are not permanent. So if if my patient were to go on a drug and develop side effects and we couldn't manage the side effects, then we would stop the drug and the side effects would go away. But I don't look at that and go, oh, man, I'm too nervous for you to try this because you might get side effects. Yeah, you might, but you might not. And so it seems like something that I would probably recommend. So I think for that group who is intolerant to antifibrotic therapy or doesn't want to take OFEV or pirfenidone for whatever reason, I think this is absolutely a reasonable option. I think for my patients who are not tolerating, I have plenty of patients who are kind of hanging on by their fingernails on one of the two drugs that are available now. They're on OFEV and they're having a lot of diarrhea, taking a lot of Imodium. They've changed their diet. We're really struggling, and maybe they're losing a little bit of weight, but we're kind of just eking through. And they're like, I can put up with it. I can put up with it. I can put up with it. That patient, I would say, man, it seems like this is potentially a better option. And the question would be, because we know that IPF lungs are quick-tempered, right? That they can get angry quickly. And so when we have stability, and I'm happy to have Dr. Mathai chime in here, but we're a bit reluctant to make changes when things are stable in a patient with IPF. But I would say in that patient who's really just kind of hanging on, maybe we would swap out, just say, okay, let's take a holiday from OFEV, come off OFEV or come off Esbriet because, appetite is down and they're losing weight, and let's try this new drug as an alternative. I think the real question will be, all right, if I have a patient on OFEV or pirfenidone and they're tolerating it perfectly well, they have no side effects, doing great, do we add this on top? And what is the benefit of that? And some data that I didn't show you, and I don't even know if I feel like it's been presented, but maybe not widely known, is those FVC values that we looked at, right? That negative 114 and negative 190, those values in the bar graphs that we looked at. Those are average values, right? And to get average values, you have people that are higher than average and people that are lower than average, right? And so if you look at within each of those groups, there's a proportion who lost no FVC. Their lung capacity was absolutely stable over that 52 weeks, including patients in the placebo arms, right? That speaks to the variable nature of this disease, right? Those of us who take care of patients with IPF, and maybe you've experienced this yourselves, I'm sure you have for at least a period of time throughout your disease course. You go in and you see your doc, and lung capacity is exactly the same, give or take, as it was 3 months ago or 6 months ago. And your symptoms aren't changed and your oxygen needs haven't changed. This disease looks entirely stable. And that can last for a variable length of time. Well, we saw that in this trial. And in the placebo group, it was something like 15% or so of patients in the true placebo arm, meaning they weren't on OFEV, they weren't on aspirate, and they weren't on this new drug, and their disease was stable. But twice as many people in the treatment arms were stable. So the way that I talk to my patients, and I do the same for OFEV or aspirate, because there's similar data there, that, what kind of, let's call it risk-taking behavior, or what type of, are you somebody who values insurance, if you will? And if the likelihood of progression is only half as much if you take this drug, and if you progress, you're likely to progress half as much, does that sound appealing to you? I think in much the same way that I talk to my patients about OFEV and aspirate, I'm going to be talking to them about this new drug if/when it becomes available. So specifically, it's much like a blood pressure medicine or a cholesterol medicine. This is not a drug that unfortunately is going to make you feel better. It's not going to make you less short of breath. It's not going to give you more energy. It's not going to allow you to use less oxygen. It's not going to allow you to be more active with your kids or your grandkids. But if it works, what we can expect is the average effect that a year from now, 2 years from now, you're going to be better off having taken the drug than if you didn't. Right? Same with the blood pressure medicine or the cholesterol medicine. You're not taking that because, my lisinopril or my amlodipine makes me feel so good, or my metoprolol or my atorvastatin, right? You take those drugs because a year from now, 2 years from now, you will have been less likely to have a heart attack, stroke, or kidney failure. Right? And I would view this drug similarly. Now, there's a couple of caveats. One is that in this IPF trial, remember I mentioned there was no difference in time to dying on the drug versus placebo. It was actually close in favor of the drug. In the sister trial that was pulmonary fibrosis, not IPF, there actually was a survival signal, meaning that those patients who took the drug were less likely to die than patients who took placebo.
Dr.
So you
Swigris,
can, yeah.
And can I just ask you, are you looking at the Q&A or the chat?
I'm not looking at anything. I'm just blabbing around right now.
Okay, I wasn't sure, and somebody actually asked me because we're trying to put everybody into the Q&A. So
okay, what are we? So let's see. Let me catch up, Dolly.
You're blabbing really good.
Am I doing all right? The
you're
voice
doing
is
great. Yeah, you're telling us what we need to know.
Okay.
Something that I had heard another physician say was that the diarrhea that was experienced with this drug didn't seem to meet the same urgency as the diarrhea that was experienced with other drugs.
Yeah, I would say that is absolutely true. I will say You know, I know at least one of my patients on OFEV and new drug. I mean, his diarrhea definitely has worsened, but it's manageable per him. You know, he uses Imodium, but feels good, feels like it's not terribly intrusive. But for those patients who are not on OFEV, I agree entirely. There is not this again, I have limited experience in my little cohort of 8 and 6 on the drug. Now I have 7 on open label. I mean, I got to tell you, diarrhea I'm not even hearing about it in the open label group. And so when I heard about it in the trial, that is true. There's not this, you know, I got to go and I got to go now. I got to get to a bathroom or there's going to be an accident. I'm just not hearing that, and I would agree with that for sure.
Yeah, I think that's something that, you know, affects people's quality of life on
Oh, yeah.
on medication. So that I think is something that is interesting
Yep.
and maybe
Yeah.
be helpful.
Yeah. The other, you know, if we're looking again on the glass half full side is Nerandomilast requires no liver enzyme monitoring, so you don't need to get your blood drawn.
What do you think the chances are that the insurance would cover 2 different antifibrotics at the same time?
Yeah, I mean, I don't know, Dolly. You know me, I try and stay out of that stuff. I have no idea. I will tell you, I mean, I would use these data to fight for my patients for sure. I mean, I'm always willing to write letters and call and that kind of stuff. And insurance companies just like to say no, right? And I think initially what happens is they'll just say no because they can't check a box or whatever. And it's somebody who typically doesn't have the knowledge. It's just that they don't see the information that they need to see, and they can easily check a box and say no. And if you just it's often pretty easy to say, I'm sure this was an oversight on your part, but this really is, FDA approved, and here are the data. I mean, so I don't know. I would hope that they would be, amenable to that and actually look at the data, and that practitioners are willing to actually dig into it and show payers the benefit of combination therapy for some patients, because I think the trial is clear in that message.
Yeah. Well, I think that can be, something that the drug company really needs to dig into as well.
Yeah.
And that'll be sort of something that I put forward to them once the drug is approved.
Yeah.
So that, if patients have that option, they can take advantage of that.
Right.
But, there may be questions in here that you're going to hit on with the rest of your presentation. So I don't want to take away.
Oh, no, that's okay. Are there, let me see, let's pause for a minute and let me just see.
So if you go to the bottom and click the Q&A.
Yeah, okay. Comment paste. Let me just see. Did your tracker data participant have had strong FEC results or were not a major declining point to see if the benefits were significantly? Yeah, I think this is, so the question is, what about subgroups of patients who, and I think it's in the supplement, like what about those patients who came into the trial and were more severe versus those who were less severe? I mean, in general, what I can tell you is that these effects seem to be beneficial in all subgroups. So whether you are very severe or not as severe, men versus women. Let me just see if I can pull that up. Let me go here. This is some breakdown that, the question was, what about those people who had, milder disease versus more severe disease, men versus women, older versus younger, heavier versus lighter in terms of weight, whites versus Asians, Hispanic or Latino versus not. What you can see here, this is called a forest plot, and what you want is all the dots on the right side would tell you that that favors nerandomilast over placebo. Now, ideally, what you want is these error bars, these little whiskers that come out that go kind of through that dot and have these little vertical lines at the end. Ideally, you want both sides of that line to be on the right side of this vertical zero line. That gives you the greatest confidence in these results. And what you can see is there's a few here where the error bars cross zero. What we have to remember here is the trial is not designed to look at these subgroups, right? It's not powered to look at the subgroups. So really when I look at plots like this, in general, you kind of want to step back and look rather than get into the nitty-gritty. So I would say in general, this drug appears to be beneficial in all subgroups, with the exception of this Hispanic or Latino versus not. Again, recognizing that we're talking about a really small number of patients, and this is a fault of our trials in general, that we enroll a lot of white people. We enroll mostly white people in IPF trials, and we could talk all day about, well, is that because IPF only affects white people, or it affects whites more than it affects people of darker skin pigmentation or other ethnicities? And the answer is maybe, but maybe it has to do with we're not reaching all the people that are affected by the disease, and people who have less access to care are not hearing about trials and so forth. So that's a whole other talk. But the only one really here that is just like, that's kind of interesting is this Hispanic or Latino group. What these results would suggest, with the caveats that the trial's not designed to actually look at these subgroups, is the drug didn't look hugely beneficial in that subgroup of Hispanics or Latinos. But in general, the beneficial effects appear similar in all of these subgroups. That was the 18 milligrams. Here's the 9. The effects look similar in that, in general, nerandomilast appears to be beneficial in all these subgroups. It looks like, just like we saw in the box plots, the beneficial effects were less than in the 18 milligram group. Let's see. That's probably all I want to say about this. This is, what are we, we're looking at symptoms here. So no difference, as I said, no difference at all in shortness of breath or cough or fatigue between treatment arms. So a little bit disappointing in somebody who's really interested in those aspects, in quantifying those aspects and determining how this disease affects patients in terms of symptoms and quality of life. So I think this just speaks to more work to be done. The window is clearly open that more effective therapies on these things that matter to patients are certainly welcome, but I think in general this is an incremental benefit and move in the right direction. Is expected FDA approval in Q4 2025 for IPF or PEEP? I don't know. I don't know what the plan is. The fact that both of those trials were published in the New England Journal in the same issue makes me think that approval may occur at the same time, even though the PPF trial was about 18 weeks behind the IPF trial. So I'm not sure. I don't know if Susan or anyone else has heard anything different. What I've heard is that approval could be as early as October, but I'm not going to hold my breath.
Yeah, what I heard, it was possibly by end of year
Yeah.
from the company itself. And
Yeah.
I think Dr. Mathai had to leave.
Oh, okay. All right. Mel asks, would nerandomilast possibly be prescribed by itself instead of aspiate if tolerance to aspiate and OFEV? Yeah. So, I mentioned that again, it would be, that would be a discussion worth having for sure with your practitioner. But I think, in my opinion, it's absolutely a reasonable thing. Could the significant decline for aspirate patients on low dose versus OFEV patients have any correlation to the fact that Fibronir and OFEV are both BI drugs and may have a similar methodology for approaching? Well, what I would say, Bruce, is the two drugs, that it is true, they're made by the same company. So nerandomilast and nintedanib, but they work entirely differently. The mechanisms of action are entirely different there. So I don't think it has anything to do with that. In the progressive pulmonary fibrosis group, is there a breakdown as to what type of? Yes, there is. So in the other trial, which I didn't show, and unfortunately I'm running out of time, not going to be able to show. Was there a breakdown? Yeah. So I think roughly 20-25% of patients had connective tissue disease, 20% had chronic hypersensitivity pneumonitis, 20%-ish had, let me just see, I'll give you the exact breakdowns here. So yeah, 30% with autoimmune disease, about 20% with hypersensitivity pneumonitis, about 20% unclassifiable, and 20% idiopathic nonspecific interstitial pneumonia, and then about 12% had other interstitial lung diseases. And let me just see. This is that forest plot that we just looked at for IPF, but this is for the PPF trial. Remember, you got to step back. In general, we want the dots on the right side of the vertical line. In a perfect world, the error bars would be on the right side of the vertical line also. But the fact that they're not is okay, because when we slice and dice into these smaller groups, we're dealing with really small numbers of patients. But if you look here at the ILD diagnosis, autoimmune, unclassifiable, hypersensitivity pneumonitis, idiopathic nonspecific interstitial pneumonia, and other interstitial lung diseases. Again, all the dots are on the right side of that vertical line, which would suggest that in general, it doesn't matter what your diagnosis is. If you have progressive pulmonary fibrosis, this drug has the potential to be beneficial for you. Okay, I'm just going to leave that up while I answer. What do I think? So what do I think of taking OFEV and mycophenolate? So caveat here, in the PPF trial, that forest plot that we just looked at, patients who were on mycophenolate were excluded from the trial. Okay, so the new drug, nerandomilast plus mycophenolate, rituximab plus nerandomilast, azathioprine plus nerandomilast, tacrolimus plus nerandomilast, we don't have data. The company is looking at doing a trial in connective tissue or systemic autoimmune disease, so patients who might be on mycophenolate or tocilizumab or any of those immunomodulatory or immunosuppressive drugs. But specific to this question, what do I think of taking OFEV with mycophenolate? I certainly have more than a handful of patients on that combination. I think in general, it's pretty well tolerated, and the data from the InBuild trial, which was published in 2020, would suggest that this combination is okay and potentially has some benefit. Some of us take 100 milligrams of OFEV daily, while some take 150. It doesn't appear that the study considered the different OFEV dosages. Yeah, I don't have those data. I'm sure the company does, and it will be published at some point. It's a really good question. What I can say is we just know the percentages, don't we, of the OFEV. I don't know, Bill. That's a really good question. I mentioned metformin earlier. Can I talk about that a little bit more? So there's a trial that's right now in the works. It's called Maverick, like Maverick horse or cowboy, or what's a Maverick? Anyway, it was a car at one time too. So looking at metformin, there's some basic data. Some of it came out of the University of Alabama at Birmingham. So some basic data suggesting that metformin does good things for pulmonary fibrosis. That is, it inhibits those scar-forming cells, and safe, quite well tolerated. So trying it in pulmonary fibrosis seems like a reasonable thing. That trial is, like I said, it's in the works, and I suspect, I'm not sure if it will start before the end of 2025 or not, but it's certainly coming pretty soon. Yeah, so Bruce asked, did the study include those who were not taking OFEV or aspirate but took the new drug? So that would have been panel B that we looked at, where we saw the FVC decline in the high dose group. Remember, it was 79. In the low dose group, it was 70. And in the placebo group, it was like 148, right? So the answer is yes, and it looks like the drug without background therapy is effective on average. Okay.
So, Dr. Swigris, I noticed
Yes.
that in the forest plot for PPF,
Yeah.
that the Hispanic group was on the right side of the line, where the IPF straddled it.
Yeah.
And do you think that's because
Yeah.
there were more Hispanics in this group and it could be better
Yeah, I think that,
analyzed?
when you're right, Dolly, again, I want us to just be a little bit cautious when we start looking at subgroups like this, that this is nice, and I think it gives you a flavor and gives you some reassurance, but don't overextend. But absolutely, in the IPF trial, I think we were looking at Hispanic numbers of Hispanics or Latinos in the 20s, where here you have at least twice as many people. So you have more statistical power to show that. I think, again, that might be food for thought or worth looking into in the IPF population, but I just wouldn't read too much into it because the numbers are so small.
Yeah, it just sort of stuck out to me.
Yeah, that's the, if anything sticks out, it's really that one.
Well, I think this has been wonderful. I don't know how much more time you have.
I have until they call me for this next laryngoscopy. I have probably 10 minutes.
Okay.
Yeah. Well, am I still sharing? I can't
You
even
are.
tell anymore. Okay, somebody unshare me, if you would.
And, I even closed that screen and it still shows up.
Okay. Richard asks, is metformin trial looking at IPF and PPF? I think it's only IPF. Don't quote me on that. It may already be on trials.gov. So that might be worth, just go to clinicaltrials.gov, type in metformin and IPF and see what comes up. But I feel like the I in Maverick, the way they spelled it, MAVRIC, is the mnemonic they're using. I feel like it's just IPF. Are you aware of any trials associated with familial pulmonary fibrosis? Yes, there is a trial that is in the works looking at uh this. I think I'm almost positive is it
Yeah, we
OFEB
need
or
to
is it?
we'll be making a comprehensive list, but
Yeah,
it's hard to
there
keep
is
track.
one looking at looking at first degree relatives of patients with pulmonary fibrosis. So a patient has pulmonary fibrosis, first degree relative, if they have an abnormal CT scan, something that we call interstitial lung abnormality or ILA, meaning there's some little abnormalities there, but not enough to diagnose interstitial lung disease. And in fact, you don't even know whether that's ever going to become anything of any clinical significance. Um, but randomizing those folks to, I can't remember if it's OFEV or if it's the new drug. I feel like it might be OFEV, but I'm not sure. And it's a 2-year long trial to see if you're less likely to develop full-blown interstitial lung disease if you're on the drug versus if not. But to answer the question, familial, I mean, the way that I deal with familial is that I might say, okay, well, this is familial, meaning that this patient has at least one first degree relative with interstitial lung disease of some kind. But my patient, I mean, familial pulmonary fibrosis is on the one hand kind of a diagnosis, but not on the other. It's really not. So if I have a patient who otherwise would qualify for a trial for idiopathic pulmonary fibrosis, I diagnose them with idiopathic pulmonary fibrosis and say, yes, they have this family member. Yes, this disease appears to run in the family, but I'm not going to exclude them from an IPF trial because I'm treating them as if they have IPF. I know that's may not necessarily be how some people view it, but I think that's probably the right way to view it.
Is that the one at Vanderbilt?
The familial one?
Yeah.
Well, it's BI, I think is sponsoring the whole thing, but Tim Blackwell certainly has an interest in that, Dolly.
I think
It wouldn't
that
surprise me if
one
he
of
were
those
to,
trials
yeah.
also includes patients having lung biopsies, which
Mhm.
surprised me that
Yeah.
on the basis of an ILA that their insurance would cover a lung biopsy. But
Yeah.
it's an interesting concept, and I think that some people have already participated.
Yeah.
There is a question there about the whole landscape of trials in IPF and PPF, and it is really quite broad right now.
Mm-hmm.
We have a lot of information on phase 2 trials.
Yeah.
Once we will put a more comprehensive list together. Some get more press than others. So we'll put a bigger list together for everybody, but understand that it is really a moving target and things happen quickly. So I'll sort of add that so that we, so that people understand that we will have another meeting, but we'll make it so that Dr. Swigris and others can actually answer your questions without having to reach back into the far recesses of their brains. But yours is really working well.
But it's true, Dolly. I think, there are so many trials. Really, we obviously cannot participate in all the trials that we get asked to participate in. There's so many trials, and this is good news for us and for patients for sure. And as Dolly was talking about before, by the time a drug hits phase 2, it has jumped through some very significant hoops. All of them would have shown that they are effective in a petri dish, effective in a mouse, safe when given to people, and even people with pulmonary fibrosis. All that has happened by the time they hit phase 2. And so there's a lot of really, I think, potentially promising drugs. I mean, I gotta say, people ask me a lot, like, oh, well, is there any one that looks more effective than others? And there really isn't. I mean, I keep going back to, I think, and I'm not a basic scientist, in my naive mind, the inhaled or nebulized formulations of drugs seems really attractive to me, that we are putting drug and high concentrations of drug right at the spot where the injury and the fibrosis is happening. Not that it doesn't get there when we take pills, but putting drug right on the spot topically seems like it would be beneficial. So, there's nebulized pirfenidone, nebulized nintedanib, nebulized nintedanib plus pirfenidone in the same drug. All of those are coming down the pike. You have metformin, you have a bunch of drugs that inhibit different pathways in the fibrotic cascade, and there's a whole bunch that look really, really promising. So just stay tuned, and I agree, Dolly, we're going to have one or two more sessions on just trials alone. Wendy asks, and I'll just keep rolling through these, and you guys can tell me to shut up or I'll leave when I get the call for this laryngoscopy. My husband is in the progressive group and has hypersensitivity pneumonitis for 10 years. His pre-OFEV FVC was 3.5, February of 22. Started study med, later found out that he was on 9 milligrams. FVC was 2.9 in August of 2023. Was on it 18 months and stayed at 2.9. Now he's on open label 18 milligrams. We are hopeful. That's great. Amy, it looked to me like people in the second group who were not on pirfenidone had less of a decline. That's exactly right. You mentioned there may be an interaction between pirfenidone and nerandomilast, but not OFEV. Perhaps I am just interpreting it incorrectly. Now, so Amy, Dolly would like to answer this question.
No, I'm just.
Oh, okay. You're just filing it through.
Yeah.
So panel B, right? The 18 milligram group lost 79 cc's, the 9 milligram group lost 9 cc's, and the placebo group lost 148 cc's. There was no drug-drug interaction with OFEV, meaning that OFEV did not chew up nerandomilast, nor did nerandomilast chew up OFEV. If you look at the OFEV, that was box on the lower left, box C. I think it was -118. OFEV plus high dose, -130. OFEV plus 9 milligrams and -191 in the OFEV plus placebo. But there didn't appear to be any drug interaction with nerandomilast and OFEV. Could I have Dr. Swigris' email and ask? You can, but just know that I'm not going to give you specific information about your, I'm not going to tell you, I'm not going to be your doc and give you medical information. But if you want to share your case with me and ask me what I think about this, that, or the other, I'll put my email in the chat. swigrisj@njhealth.org. Okay. What else, Dolly?
I'm muted. I was doing my best work because that happens when I'm muted. I think we have gotten through all of the questions. And if you want to make sort of a closing statement about the drug or whatever, I think that would be great.
Yeah, I mean,
we can close out the meeting.
Okay. Yeah. So my take here is, I think that in terms of efficacy, meaning how well is this drug doing what we hope that it does, I think I would put it in it's nice. It's a step forward because it is at least as effective from what I see as OFEV plus pirfenidone or pirfenidone. I think really intriguing that panel B, where those patients who were not on background therapy And the decline of 79 or 70 cc's is less than we saw with OFEV or pirfenidone back a decade ago. So I think that's nice. I think in general, this drug is very, very well tolerated. And I think it's a nice alternative for sure to OFEV or pirfenidone. And I think the question of whether you would want to add it to OFEV or pirfenidone if you're tolerating those drugs perfectly well is an individualized discussion, but it's certainly a discussion I'm going to be having with my patient, and see no reason why I wouldn't add it on top as a trial. So stay tuned. Our hope and expectation is later in 2025, we'll have this drug available as an option to offer to you. Feel free to email me. I know some people cringe when they're like, oh, you give your email. I give my email to everybody. Email me at will. I will do my best to answer questions. Like I said, I won't give medical advice, but I'm happy to hear from you. And I really appreciate the opportunity to talk to you today. I hope everybody has a great day and an enjoyable summer. And I will, I'm sure, see you again soon.
Yeah. Thank you, Dr.
Thanks for having me, Dolly.